Okay, I think I'm going to start now. So I'm going to talk about ECG changes in STEMI. And patients with STEMI, they may present with chest pain, pressure relating to jaw or left arm. Sometimes I see patients with pain in the right arm, shortness of breath, diaphoresis, nausea, GI symptoms, indigestion. You mentioned they have it. So they need to be sent to the cath lab immediately for reperfusion therapy. And ruling out STEMI is the main reason why we do 12-lead ECG. So it's critical for nurses to learn ECG changes to identify STEMI prior you get the provider. Basically, the sooner STEMI is identified, the better the chance for survival. So this is the 12-lead ECG, and I just want to mention that you see the bottom two, it gives you 10-second strip, V1 and 2, and it depends on ECG machine. Sometimes it's going to give you 3 leads instead of 2. The rest of the leads is going to be only 2.5 seconds. All these leads on the top here. So we use 10 electrodes to create 12-lead ECG. We use 4 electrodes for limb leads, and precordial leads or chest leads, we use 6 electrodes here. And I'm not going to mention placement because you all know the placement. I just want to mention about the right-sided ECG. Once in a while, a provider may ask you to do it if we suspect right wall involvement, MI, and also patient in dextrocardia, you need to do the right chested ECG. So with the dextrocardia lead placement, you just place the way it shows on the picture. We want to here, and then with the left arm, you just flip them left to the right, same thing with the legs. So what the leads give us a view. Chest leads or precordial leads give us presentation, a horizontal presentation here. And limb leads, they give you frontal presentation here. So this is a closer look, the horizontal presentation. You have V1, V2, it's looking at the right ventricle, V3, right ventricle here. Then V2, V3, look at your septum here. V2, V3, V4, looking at your anterior wall. V5, V6 looks at the lateral wall. And we don't, I'll show you later how to do V7, V8, but it looks at the posterior wall. So this is another picture, what the leads look at. So you can see V1, V2, right ventricle here, septum. So this picture actually helps me because I have this picture in my brain and then I don't need to memorize anything. So you can see 3A, VF, 2, they're looking at inferior wall. That's how I remember. So localizing the infarct, the ventricular myocardium is divided into regions called walls, which correspond to the leads of the ECG. And as I said before, I have picture in my brain, so I don't need to memorize any one of this stuff here. Let's talk about AVR lead because it's different from the rest of the leads. So all waves in AVR, they're negative. In contrast to other leads, in dextrocardia, although the P wave is going to be upright. And lead AVR, it looks from the right upper side of the heart. And also it gives you reciprocal information, and I'll mention later what reciprocal information is. It gives you a reciprocal information on the left lateral side of the heart, but it's already covered by leads AVL, 1, V5, V6. That's why we kind of ignore AVR lead. So this is again the horizontal view, and just look at the progression of this R waves. You see, it gets bigger, bigger. I mean, not bigger, taller, taller, and taller. And V6 is really tall. Again, so this is the normal progression. That's what you expect in patients with any pathological condition. RS ratio here less than 1, and it's looking at the right wall. V5, V6 ratio, RS ratio greater than 1 is going to look at the left ventricle. And if RS ratio is 1, it's the transition between right and the left ventricle. And transition zone usually happens in V3, V4. So here's another picture of horizontal view and the limb frontal view. Same thing here. As I mentioned, when you look at inferior wall, it's going to be 2 AVF 3. Here, you look at the septum. Septum would be V2, V1, V3, V4 anterior, V6, V5 lateral wall, and lateral wall would be AVL and 1. So STEMI refers to a complete occlusion of coronary arteries. So where this elevation occurs, ST elevation will indicate which heart wall is infarcted. It's going to have ST elevation. It has to have ST elevation in at least in 2 contiguous leads. And contiguous leads are the leads that looking at the same wall of the heart. And it also will indicate which coronary artery is involved. So here's the normal ECG picture. ST segment comes after QRS on EKG and before T wave. So we're looking at this segment. And it represents the initial phase of ventricular repolarization. And it should be at isoelectric line. So usually I look at this in PR interval here. This gives me an isoelectric line here. So then we need to find J point. And J point is the point on EKG where QRS complex meets ST segment. And this is important for recognizing ST elevation. So ST elevation is significant. It's defined as greater or equal. I'm going to talk about the boxes here. Greater or equal 1 box, small box here, above the isoelectric line at the J point. In leads V2, V3, it's different. It needs to be slightly taller, 1.5 in women and 2 boxes in men. So here it gives you different presentation of ST elevation. When you see concave here, it's not as bad as convex, because we see this elevation, concave elevation in many conditions, especially with our patients. You can see it in vasospasm and pericarditis, left bundle branch block, left ventricular hypertrophy, ventricular pacemaker, patients in stroke with increased ICP, patient in hypothermia, patient with blunt chest trauma, and Brugada syndrome. The convex elevation, that's the one you need to worry about. So ST elevation indicates full thickness cardiac muscle injury, and pathological Q waves indicates muscle necrosis, and T wave inversion indicates muscle ischemia. So again, you can see elevation here, different way, but it's bad. Development of Q waves here, T wave inversions here. And we're going to talk later about the reciprocal ST segment depressions. So an EKG can help us to, it tells us the approximate age of an infarct. And there are 3 main components of the EKG after the onset of an acute MI. Changes in T waves, ST segment, changes in ST segment, changes in QRS complex. And it's all due to effect of ischemia, injury, and infarct. So you see the normal EKG here, ST elevations here, and really bad elevations here. So let's talk about STEMI progression. You start with very tall T waves. Sometimes you don't see it because it happens so fast. Sometimes it only takes minutes to see those tall T waves. So it takes minutes to an hour, and then it resolves. Then you see ST segment elevations. And it has to be in 2 contiguous, at least in 2 contiguous leads at the J point. So initially it's concave, and then it's going to turn into tombstone presentation. And tombstone, as we all know, it's bad. Then you see reciprocal ST depressions in the, you may see it, it doesn't happen all the time, in the opposite leads. And then ST segment returns to baseline. It takes about a week. Q waves would develop within hours to days, and T wave inversion can be temporary also. So as I mentioned before, ST elevation would last from a few hours to several days, but those ST elevation that last more than 2 weeks, it's indicative of formation of ventricular aneurysm, in which the necrotic ventricular wall becomes thin and bulges. Reciprocal changes refer to mirror image of EKG that occurs in leads opposite from the site of an acute MI. And reciprocal changes usually appear in the form of ST segment depression and leads distance from the site of infarction. Later, I'll talk about reciprocal changes. The T wave inversion are deep and symmetrical is important here. And T wave inversion can remain on EKG for months or even indefinitely. Also, as I mentioned before, T-wave inversion can be found in other conditions. And we see this condition all the time here, ventricular hypertrophy. So we see pretty much all of our patient has a T-wave depressions here, inversions. Also, you see this rounded appearance of ST in the JAK toxicity in hypokalemia. And you can see other reasons for T-based inversions. So here's another picture. It shows you symmetry and asymmetrical negativity. So this is LVH patients with LVH, and you see it's asymmetrical. And patients with MI and myocarditis, look at the symmetry here, and this is bad. Let's look at the R wave progression. As I mentioned before, you look at R wave and it gets taller, taller, and taller. With infarct, you can see there is no such progression. So here you don't see V2, V3 getting taller, they're pretty much the same. So I would think probably it's like septal anterior infarct here. So let's look at QRS complex. So Q wave. I'm pretty sure you all know this, but just to remind you. So the first downward deflection is Q wave. Any upward deflection is R wave. And any downward deflection after R wave is your S wave. So let's talk about Q waves. Pathological Q waves are defined as one small box here, Y, is duration. And any Q waves seen in V1, V2, and V3, they're always pathological. And you can think of Q waves as electrical holes. There is no electrical activity there. There is scar tissues. And pathological Q waves, they are not an early sign of MI, but generally takes hours to days to develop. And if MI is perfused early, then tissue would recover and pathological Q waves disappear. And Q waves can begin hours to days after infarction begins and can last for years, even forever. So look, leads V1, V2, and V3, they usually start with initial R wave. You shouldn't see a Q wave here. Small initial Q wave, you'll need to look out for MI. In those leads, V1, V2, V3. So just remember, with AVR lead, it's normal to have a deep Q wave in that lead. To consider pathological, the Q wave should be greater than 0.4 small box in duration here. And it has to be 1/4 of R wave in amplitude. And duration is more important than amplitude. And as you can see, this is normal without infarction. With infarction, everything is going to be dragged down. So negativity happens with infarction here. So EKG changes are significant when they're seen in at least two, not one, at least two contiguous leads. And two leads that are contiguous if they're looking at the same area of the heart, like inferior, septal, lateral, anterior, posterior. So MI location. STEMI are classified based on where they're located anatomically. So which leads are they affecting on the EKG? And basically, I usually don't memorize this because I have this picture in my head, so I can remember where everything is. So let's talk about reciprocal changes. So EKG does not make a diagnosis of acute MI. Elevated cardiac enzymes do, but it takes time, like hours, to confirm positive cardiac enzymes. So we use EKG as a management tool to reduce diagnostic time window. To distinguish ST elevation MI from other causes, we'll look at reciprocal changes. Reciprocal means from the opposite side, and reciprocal changes in the acute elevated MI means the presence of ST depression in the lead opposite. So just think ST depression in the leads opposite to the injured area. And here's an example. So you have acute lateral MI with ST elevation in lateral leads, and your lateral leads would be V5, V6, AVL1, the leads looking at the side of the heart. You see elevation here, and the opposite, the inferior leads, you would see depressions here, reciprocal changes. So you should see in inferior leads, the leads looking at inferior wall, 2, 3, AVF, you should see this negativity here. But I just want to make sure you understand the absence of reciprocal changes does not rule out acute MI. But the presence of reciprocal changes makes the diagnosis of acute MI more likely. So here's another picture. This is with the posterior wall, and you don't see it because it's in the back. You need V7 and V8 lead to look at this, and I'll show you how to do it later. You would see reciprocal changes, depressions in V1, V2, and V3. So we all know it's common for an infarct to involve more than just one anatomical lead group because the coronary arteries, they supply multiple areas of the heart. So you see patients with anteroseptal, anterolateral, inferior posterior infarcts. So let's look at the right coronary artery here. It supplies all of the right ventricle, supply most of the conduction system above the AV node or at AV node and SA node. So what happens if this artery is affected, infarcted? So you would look for sinus, bradycardia, junctional rhythm, and first and second degree block type 1. The left anterior descending artery, it supplies 40% of left ventricle. It also supplies septum, supplies most of the conduction system below AV node. So below AV node, you would expect to see high degree blocks here. The circumflex artery, it wraps around the left side of the heart, supplies blood to the left atrium, part of the lateral surface of the heart, and rarely the inferior and posterior. Also, keep in mind it supplies SA node 40% and some of AV bundle. Posterior descending. So usually it branches off from the RCA, you see a picture here, and we call it right dominance. In small percentage of people, it can branch off from the left, from the circumflex artery, and you call it left dominance. And some people can have it supply from both artery, and it would call codominance. Let's look at the lateral wall here. And complication here, because it supplies some of the septum. So complication would be due to conduction and septum. So you would see higher degree blocks there. Inferior wall MI, and we see it a lot, 40% would have right wall infarct. And this patient, we need to be careful with this patient. They may present with hypertensive episodes. We should avoid nitrates and morphine because it's going to even drop blood pressure more. We need to think about maybe they need fluid challenge. And these people have abnormal response to beta blockers and calcium channel blockers. I had one patient a few months ago. We started him after inferior wall MI. We started him on CORAC. And when I saw him, his heart rate, he was tachycardic. So I decided to increase his beta blockers. Sure enough, a few hours later, he went into junctional and he ended up with a pacemaker. So we need to be very careful. And why? Because as I mentioned before, RCA supplies blood to SA node and AV node. And in this patient case, SA node was affected and patient up with Brady and junctional rhythm. Posterior MI. So it happens with the occlusion of RCA or posterior descending artery. And it often, because it's another anatomical location, it's very near to the inferior wall. So inferior wall MI would share with posterior wall MI. And 12 lead EKG, I'll show you in the next slide how to do it. You will see depressions, as I mentioned before, in V1, V3, and that's how you do posterior lead. And I usually never done it, but that's how it can be done. So V7 would be your V6, this would be your V5, and V9 would be your V4. So let's look at EKG with acute inferior MI. So inferior wall, you should expect elevation and 2, 3, and AVF, and you see these elevations here. Then you're looking for reciprocal changes, and reciprocal changes would be anterior lateral wall. So you look at V1, some depressions here. You can see depressions here, depressions here, depressions here. Yeah. So this is really obvious acute inferior MI. You can see this huge elevation in lead 2, AVF, and 3. And you can see obvious depressions in V1, V2, V3, this leads, and actually 1 and ABL. Septal wall MI, the significant amount of conduction component is in the septal area. So you expect high degree blocks, bundle branch blocks too. And as I said, it's very rare you see only septal MI. It comes with anterior or lateral involvement. Anterior MI is pretty bad. That's all I want you to remember, because it covers large area here. And you can see septal wall is involved, lateral wall is involved. Patients with lateral, with anterior MI, you look for ventricular arrhythmia, VT, VFib, and cardiogenic shock and high degree AV blocks. So this is your anterior. You look at ST elevation, V2, V3. You see huge elevations here. You should see depression. Reciprocal changes would be depression in inferior wall, and you see depressions here. Let's talk about valence wave. Actually, Grace had this patient. This patient had a LAD lesion which was stented, but post-cath, he had episodes of chest pain, and he had this huge T waves inversion. And so valence waves, they come with either huge, deep T wave inversion or biphasic T waves here. So, and with anterior STEMI, you can have De Winter sign. So with De Winter sign, you don't have as obvious ST elevations, but you would have tall, symmetrical T waves in precordial leads. You can see upsloping of ST segment depression here. And you would have reciprocal ST elevation just in this lead AVR. So this, you are not looking for elevations, just this picture would rule patient in for STEMI. So again, T waves, you can see huge De Winter T waves here. It's very hard to diagnose STEMI in presence of left bundle branch block and pace rhythm because it's associated with ST elevation and discordant T waves. And I talk in the next slide about discordant T waves. So it mimics or masks acute MI. So we use Smith modifies Barbosa criteria. And when you see new left bundle branch block and patient complain of acute chest pain or shortness of breath, should be concerned for MI. So this is left bundle branch, normal and pace rhythm. So you can see discordance here. So what's discordance? A J point or ST segment moves in the opposite direction of QRS complex here. In those leads, and it's usually V1, V3, where the QRS complex has negative deflection. You can see here ST elevation, a J point elevation here, which is normal. And you can see some depressions here. So it depends, like this is with V1 mostly, V2, you can see, like you look at this. So discordant, it means in the opposite direction. T wave goes the opposite direction of QRX. So his QRX, the opposite direction upward is your T wave. So that's what we call discordance, opposite of QRS. T wave is opposite of QRS. So how do we diagnose MI in this patient? So this is a modified Barbosa criteria with a, so you need to have one of this criteria to rule in MI. Concordant ST elevation, so elevation, same direction. It has to be at least one box in any lead. With depression, it has to be more than one box depression in lead V1, V2, and V3. Or discordance would be the opposite. You see QRS, the opposite. So you have to have ST elevation greater than 1/4 of S wave. So 1/4 is the clue here. So as I said, positive finding of just one of these three criteria would meet criteria for MI. So I want to show you ECG, again with patient with left bundle branch block and positive troponin. You can see AVL here, ST elevation. So, and let's look at the lateral wall. You see some depressions here. So this is using positive Barbosa criteria in patient with V-pace rhythm. Again, you see concordant ST depressions and V2 to V5. And this is patient with posterior MI. Okay, I'm done. Any questions?
Vera, that was great. Thank you so much.
Oh, you're welcome. I mean, probably it was too fast, but I just want to make sure I'll fit everything in 30 minutes.
Yep, and it is recorded, so we can always go back and re-listen to it.
Yeah, thank you.
Hey, Vera, great job. It's Elenia.
Hey, Yelena.
I'm going to ask you to do this lecture for the APP fellows, okay?
Okay, thanks.
All right.
Very good, Vera. Thank you.
Thanks so much.
Very
Vera.
good.
Very knowledgeable.
Yes, very helpful. I'm
Very
going to
good.
utilize this as a reference.
What
I
is
thought
that?
the fellow was asking for that type of lecture.
Thank you,
Oh,
but you
yeah.
know, is that I learned a lot just doing it myself. Now it's like I feel good looking at the EKGs.
There you go.
There you go.
Thank you. Thank
You'll
you.
have to share some of those pictures that you have memorized in your head, though. 'Cause
Yeah.
we all need to memorize them too.
Maybe
those are
because
great
I was
pictures.
looking at this for the past 2 weeks, so maybe it's in my brain. But thank you.
Thanks, Vera.
I see everybody.